All right, we are very excited to have back in studio Dr. Gustaaf de Ridder. He is Transfusion Services Director at Geisinger, also the Medical Director of Patient Blood Management. He has been an audience favorite. He recorded a previous podcast on informed consent. Dr. de Ridder, that podcast has gotten so much attention, even from medical community. We've gotten so many congratulations. We're going to link that first recording with you in this podcast so that if you haven't listened to it, we highly encourage you to go back to that very engaging conversation. But welcome again to our show, Dr. de Ridder.
Thank you for having me. I'm so happy to be on video this time.
Yes. And of course, we know that Marianne is your sidekick at Geisinger, and you guys just work so well to advance PBM. So thank you so much.
Absolutely.
I'm not sure who's the sidekick. I think it's me, but go ahead.
Right. We're going to ask our audience today, do you know your blood type? And if you do you know why that is important? We're going to be talking all about our blood type, cross-matching, and why that should be important to you and how it plays a role in your blood health. We're going to talk about some transfusion practices that you probably don't know about. Many of them I don't know about. Even in nursing school, I learned the 4 different blood types, A, B, AB, and O. I learned that you were positive or negative, and that was about the extent of my training in nursing school. So I think we have a lot to learn here. Dr. de Ridder, set the scene. Tell us about blood typing and the ABO group system and why it should be important to all of us.
Absolutely. So the ABO blood group system is the most important blood group system. There are hundreds of different blood group antigens, but we're really just going to talk about the ABO and the RHD system today. So ABO, it's your blood type A or B or AB or O, is the fundamental typing that we do for different people's blood to see who can give blood to another person, who's compatible with another person. We don't have to give ABO identical blood. If I'm an A, I can get blood from an A person, or I could get blood from an O person. If I'm a B, I can get blood from an B person or an O person. If I'm an O, unfortunately, I can only get blood from an O person. But if I'm a lucky AB person, I could get blood from anybody, an A, a B, an AB, or an O person. So that's what we mean by ABO compatible. And the reason why it's so incredibly important is because if you give somebody an ABO incompatible transfusion, you can cause major organ damage or death. In fact, when transfusions first were attempted before 1900, we didn't know about ABO groups. And so we were just rolling the dice, as it were, to try to save somebody's life. And trauma, occasionally we would hit it right and a miracle would occur and the patient would survive. Of course, occasionally they would have a massive immediate hemolytic transfusion reaction. And the ABO hemolytic transfusion reactions are quite serious, and sometimes they would die. So that's ABO.
Now, I heard in that explanation that seems like O can be given to everybody. So is that why O is considered a universal donor? Talk about the universal donor.
That is the basis for the concept of universal donor. If you are unable to type a person's blood, if you go to the hospital and you need a blood transfusion, you're going to have a laboratory test drawn called type and screen. If that type and screen can be tested and interpreted in a timely fashion, the hospital should give you type-specific blood. So if I'm an A, which I am, I'm an A pos. Talk about that pos part in a minute. You should get A blood. If you're a B, you should get B blood. But if you can't test the person in time to give them their blood transfusion, and now we're talking about an emergency. This should only be under emergency conditions that this happens, when somebody is truly bleeding to death or so anemic that they're going to potentially die. Then you give them emergency release universal blood, which would be group O, because we consider ABO incompatible transfusion to be a never event. So from an FDA, and the Food and Drug Administration regulates blood transfusion, from an FDA perspective, that the ABO incompatible transfusion is a never event. So if that happens, it's a huge big deal in your hospital.
Okay. So I'm A negative. What's the difference between your A and my A blood grouping, that positive and that negative?
So now we're getting
Oh,
to it.
I love that. I didn't know you were A negative.
I am an A negative person, and Dr. Gustav is an A positive person.
I'm AB positive, so I don't worry about
Woo!
anything.
So when we say positive and negative, we're really referring to the RHD protein or the D. When we say RHD or D interchangeably, that's what we're talking about. And so I have a protein on my red cells called RHD or D, and Sarah does not. So what that means is that if I get blood from a person who has D on their red cells, and that is 85% of potential donors, that's very important, 85%, I'm not going to have any problems with that. I'm not going to make an anti-D antibody. My immune system is not going to react against that D protein on the Marianne's red cells, for example. However, Sarah, if she got transfused with my blood, my A positive blood, she stands a chance of making an immune response against that D protein. And this is actually the basis for why we give pregnant women who are RHD negative RH immune globulin or RIG. Many of you guys listening might know that as Rogam, but Rogam is a brand. Generically, we call it RIG. That prevents alloimmunization, meaning Sarah's immune system recognizing the D protein on red cells from a baby if she was pregnant. Sarah, I believe you had do you have personal experience with this?
Yes, I have 2 children. And so during those pregnancies, I was given Rogam, one halfway through the pregnancy and one at the end of my pregnancy, just in case baby was positive. They didn't want me to make those antibodies, I guess, because future pregnancies could be at risk.
Exactly. So what Sarah is talking about is something where the mother's immune system, if she is RHD negative, can attack the red cells of the baby and cause the baby to become very anemic sometimes. That's preventable by giving Rogam. In your case, Sarah, did it work? If you don't mind my asking, did you make an
Yes.
anti-D?
I think both babies were positive, but they were healthy and second pregnancy was fine. So obviously the Rogam worked.
Fantastic. Program is truly a triumph of public health efforts. There are a few things that we can really point to and say that program works. That most certainly does. So I'm glad. But the RHD thing, 85% of potential donors are RHD positive. So that means that 15% are RHD negative. What that means, if you multiply the frequencies of group O, which is the most common blood group, about 45%, times 15% of people who are RHD negative, you end up with about 7%, just under 7% of potential donors who are group O negative.
Gotcha.
That's really the answer for when you ask what's considered the universal donor. Traditionally, we look at that as O negative individuals, and that's setting the stage for most of this discussion.
Yeah, so that makes sense. There's a lot of demand for O negative, right?
That seems like a lot of pressure on the system.
Well, if hospitals were ordering 5, 6, 7, 8% O negative, that probably wouldn't be a problem, right? And these are USA statistics. The frequencies of these things do vary by nation, though we're really talking about the USA here with these numbers. However, the biology of this applies worldwide, okay? We aren't ordering 5, 6, 7, 8% O negative. In 2023, the American Red Cross shipped out approximately 13% O negative. The rest of the blood centers in aggregate across the United States shipped out over 10% O negative. Maybe not a large number, but the difference between 10 and 13% and 6.7% is a huge difference.
Yeah.
So any of you who are blood donors out there listening who are an A negative or a B negative or even better, an O negative, I think you know that the blood centers where you donate are calling you and texting you and emailing you. There's a thing called donor fatigue that really comes into play here.
Absolutely.
Are we giving people with negative antigens, are we giving them positive blood intentionally?
That's a great question. For many years in emergency situations, patients have been switched to RHD, I'm going to call it agnostic, blood products. So if your blood bank is running out of, say, A negative, Sarah, let's say Sarah comes in, her arm got bitten off by a tiger.
Yes, that tiger bite.
She plays with tigers. and her arm got bitten off, and she's bleeding to death. And she goes to her blood bank, but to her hospital, and the trauma surgeons are working on her, but the blood bank is running out of A negative units. And then they've switched to O negative, and they're running out of O negative units. They didn't have many to start with because there's a chronic shortage. So what are they going to do? They will switch to A positive. In that scenario, we have a lot of experience. This has happened for decades. As long as we've been transfusing blood, we've had these emergency switch situations. I will say, before we get into a practice that we've been doing at our hospital system since 2020, expanding that switch concept, I want to talk about the risks of alloimmunization, of making an antibody against D. Why do we care in the first place? What's the big deal? Well, there are two things. The first one is that hemolytic disease of the fetus and newborn. That's the proper term for that immune problem that we were talking about with RhoGAM, where Sarah may have made an anti-D, and then that anti-D antibody could then potentially harm the blood cells of her fetus, her baby. And so there's that thing, okay? So women of childbearing potential can be at risk for HDFN, hemolytic disease of the fetus and newborn. Then the other thing is a hemolytic transfusion reaction in the recipient, in the person who gets the blood. So you can, if you have been sensitized, if your immune system has made a response to D, and you get D positive blood in the future, you can have a hemolytic transfusion reaction. Now, they tend to be mild to moderate with these Rh proteins, the RHD included. Mild to moderate most of the time. Then you just support the patient with supportive care, and they will survive that. But it is an unpleasant possibility. So that's why we care.
When we inadvertently, or even on purpose, because we have to, expose a negative to a positive antigen, do we just give them RhoGAM like we do pregnant mothers when they're pregnant?
Great question. Our trauma surgeons at Geisinger certainly did ask us that question as well. The answer is no, we don't. But the reason for that is simply the dosage of the RhoGAM you would have to give to potentially prevent sensitization to D protein is staggering. Let's get back to Sarah's tiger bite. We saved her life. The surgeon sewed up her arm, and we gave her 2 units of O positive whole blood. That's what we would choose to use for trauma at Geisinger. To try to prevent her from making an anti-D antibody, dosing that RhoGAM the same way we would for a pregnant woman would require 34 vials of RhoGAM. I don't know about you, but we give those intramuscular, right? So like in the thigh or in the buttocks. Can you imagine getting 34?
No, that's a big nope.
we don't even have that much in the hospital. I mean, that's so. I see. Yeah, good question though. The other thing is we also don't even know if it would work.
So who really needs the O negative? We have so little of it. Who are we giving this to?
There was a study in the mid-2010s out of the Best Collaborative Optimus study. Nothing better has been published since. It's a little dismaying to look at the results of that study and understand that more than half of our O-negative blood goes to not O-negative people. So more than half of our O-negative blood, sourced from those 6.7% of donors, goes to not O-negative people. More than half of RHD negative products overall, including the O-negs, the A-negs, the B-negs, goes to not RHD negative people.
Why?
Why is that? So traditionally, we have matched RHD for all recipients. So men, women of any age, regardless of whether they still may or may not become pregnant. So that's the baseline demand, is giving RHD negative for all those RHD negative or unknown patients. However, there are many hospitals out there that transfuse a lot more O negative than they probably ought to, because from an inventory management standpoint, it's simpler. Imagine if you're a small hospital in a rural area, or any hospital, if all you ever stocked on your shelf was O negative, well, you wouldn't need to do any product selection. You just give O negative to every patient, right?
Mm-hmm.
That actually still happens today in some small rural hospitals.
In your opinion, is there an ethical concern here? Because I do see that in a lot of rural hospitals. We bring a patient in and we type and screen them. So patient thinks they're they're being screened and typed for appropriate cross-matching. And even when they get a transfusion, I don't think it's explained to them that we are not giving them actual blood that's cross-matched to them.
I don't think giving uncross-matched emergency release O-negative blood people is dangerous. I don't really think that there's an ethical concern to the patient. I do feel like it's a little bit unethical to add that strain to the donor population. So we talked about informed consent a lot in our first podcast episode, and the informed consent process really should begin with the donor. So from vein to vein, we tell donors, oh, you're going to save a life. You might save 3 lives. You hear these things all the time, right? That's true. Maybe. Appropriateness of transfusion is beyond the scope of this podcast today. But when we tell those O-negative donors that they're super special, that we really need their blood because there's so many people out there who need this O-negative blood,
right?
We have to actually take a step back ethically and look at who are we giving this to? Now, to get right to your question, two questions you had we haven't answered. Are we intentionally using RHD positive blood in RHD negative people? Who really needs that RHD negative blood? In 2020, at the beginning of the COVID pandemic at our hospital system, we did, because of our emergency shortages that were real at the time, and we still and really not lessened much since the onset of COVID. Chronic blood shortages have just become our reality. We started giving RHD positive blood to men in general, and not just in emergencies and traumas, but across the board, with a few exceptions. Bone marrow transplant patients, some sickle cell patients would still be honoring that RHD status. But for men in general, we started giving blood type specific, yes, RHD agnostic. And for women over 50, the same thing. Now, why is that? I just told you that the 2 main concerns with RHD are hemolytic disease of the fetus and newborn. Men can't have that.
Right. For 50, it would be very rare for there to be a fetal. Yeah.
Exactly.
Yeah.
The 50-year-old cutoff is arbitrary, admittedly, but we have to draw a line somewhere, just like we do for our type switching on emergency conditions in the past. This was 50 years old is kind of a standard threshold. So what we found, and this is a manuscript we're working on publishing now, it's in preparation, is that now over 770 patients for whom we have follow-up testing who have been transfused RHD positive blood who are RHD negative, we've observed a 19% rate of immune response. So 19% of them have made an anti-D antibody. Ask me how many hemolytic transfusion reactions we've seen.
How many? 0.
It's 0. In case anybody doesn't understand that hand signal, that's 0. 0 hemolytic transfusion reactions associated with anti-D from a stimulation from a transfusion event. So patients who made anti-D from getting transfused have had 0 hemolytic transfusion reactions, either associated with the initial transfusion or subsequently now from 2020 to 2025. So we've spared now over 2,000 units of RHD negative blood associated with those patients. And this actually is in line with prior publications from the trauma literature. This work is largely led by Dr. Yazer out of Pittsburgh, observing rates of alloimmunization against D somewhere in the 25 to up to 40% range in the trauma literature. So our current study in our current population of patients who meet this description, we are seeing 19%. And this is routine transfusion, not just trauma. So who needs that RHD negative blood? Okay, not men, not women over 50, or women beyond childbearing potential. So who actually needs it? We feel very secure now in our inventory of O negative and RHD negative, so A negative, B negative blood for those women under 50, for those, say, pregnant women who then have a peripartum hemorrhage. Severe bleeding around childbirth is a thing that happens not infrequently. And sometimes we have to transfuse those women if they consent to it. We will transfuse them and help save their lives like that. And this way we have enough RHD negative blood to always fulfill those needs for those patients. And we usually don't have to switch types to, say go from A negative to an A positive because we have enough blood.
Mm-hmm.
So to Sarah's question and to add to your discussion of consent, what if a patient finds out that they need blood and we're going to give them something mismatched? Like, what do we do there? Do we say, oh, you have to take this, or you had a tiger bite, we need to give you this?
Patients don't have to take anything. So the right to refuse or accept a blood product belongs to the patient. Blood is a voluntarily donated limited resource. Most all hospitals have very robust protocols, practices from the blood bank to select the right product for the patient based on all kinds of things, but the biology that we've just described in this podcast, but also the inventory constraints of that hospital. So no, we really don't allow patients to, pick off a menu. I want this, but not that product, but I want that flavor of that blood. Not really. If the patient wants to have more information about the product, so let's say I'm offering Sarah an A positive unit and she's A negative, and she has concerns. If I'm her provider, I really have the duty to explain the risks and benefits. I can tell you that even for a woman of childbearing potential, the risk of having a severe problem with a baby downstream, if she's exposed to RHD positive blood, is less than 1%. That's also worked largely out of the best collaborative. So if your risk, even as a woman of childbearing potential, is less than 1% of having a severe downstream complication, the risks of that quote unquote mismatched transfusion are vanishingly small when we're talking about RHD specifically.
So just to drive home the point, why are we talking about this today? If there's no reactions, right? What's the harm being done?
I think the greatest harm being done around RHD is overutilization, driving donor recruitment efforts that are out of proportion to true clinical need. All those donors that get fatigued by constant, I don't want to call it harassment, because the blood centers are operating with good motives. So these are good organizations that are really trying to help people. The demand for these products is out of proportion for the RHD negative products. Instead of being able to focus on, say, iron deficiency in chronic red cell donors, something that should be addressed this is a PBM topic, patient blood management topic. This is donor blood management, but they're still people who deserve their blood health to be intact, right? So instead of being able to focus lots of efforts on that issue, as an example, we have to focus efforts on getting all of those O-negative donors in, getting all of those B-negative donors in, okay? That's one harm. The other harm, I think, to doing too much RHD negative transfusion and having this mismatch between the supply and the demand is that large organizations like AABB, the Association for the Advancement of Blood and Biotherapies, are forced to focus large amounts of effort on those donor recruitment topics, the strategies for new donor recruitment and existing donor retention. These dominate a lot of effort that could otherwise be applied to more patient blood management focused efforts in maintaining blood health and avoiding transfusion.
I'm glad that you brought that up, because that was my next question, is how does this discussion really relate to patient blood management? We know that we always say patient blood management is about managing the blood of the patient, not the blood in the blood bank. So how does this relate to good patient blood management?
Well, I think this is a really, big picture kind of a discussion. We're discussing really like social good, the societal level pots of resources. Where do we want to apply our resources? The blood industry and PBM are, competing for the same pot of resources. When we have an excess utilization problem, like I'm describing, that cuts into those resources that we can apply to more blood health or PBM-oriented activities. But the reason why it matters is because we know that if transfusion can be avoided and anemia can be managed, blood health can be maximized, as we like to say, for any given patient, their outcomes are better. you know, PBM is not just about bloodless medicine. Bloodless medicine exists at the end of a spectrum for PBM, right? It's the
Right.
extreme product of patient blood management. It's a wonderful discipline. Also, it's beyond the scope of this episode. PBM is more in the middle, where we're trying to right-size transfusion. We're trying to make sure that we can minimize transfusion, because now we have abundant evidence that unless you're actually dying of your tiger bite, you really should not be transfused. So, we want to free up as much resources as possible for patient blood management.
I think the best gift we can give to a donor to thank them is to ensure that we're being the best steward of this product that they have given us. And by using patient blood management techniques, we can do that, and we can reduce the need, and we can have better patient outcomes and be respectful of our donors.
Well said.
What is the PBM impact of sparing those RHD negative and O negative units that we use in men and older women?
It's a great question. We safeguard our special products, those O negatives, the RHD negative products, for at-risk groups of patients who really truly need them. So we mentioned the peripartum hemorrhage, right? So the obstetric bleeding patients certainly are one potential group. Stem cell transplant patients of certain types require sometimes O negative specifically blood, otherwise A negative or B negative, to get through their transplant period safely. If we couldn't transfuse patients, we pretty much couldn't do transplant like that, bone marrow transplant. So I mentioned sickle cell disease patients. Sickle cell disease patients often require chronic transfusion, either a simple transfusion or an exchange transfusion, and have a lot of blood matching needs that are a little different from your average patient. Sometimes it's required to source the matched blood from our RHD negative or O negative inventories. So if we protect that inventory from excess use in a person like, say, myself, I would not consent to getting transfused much at all, but certainly not take RHD negative blood inappropriately. From a PBM standpoint, we're getting the right blood to the right patient at the right time and protecting the blood health of those special populations of patients who truly need that special product. Because if you do become allo-immunized, so make an antibody against RHD or any other of the hundreds of antigens that we're aware of for red cells, that becomes an important piece of your blood health. That is a thing that stays with you for life. Now part of your blood health. So this discussion, while I realize is very much blood product and sort of blood bank centric, definitely intersects with PBM that way.
Yeah, I think I would agree with that. What is your takeaway that you would like people to really have clear in their minds?
I think everyone needs to know their blood type. I would like for the public to understand this concept of RHD versus what is ABO. So we really do need to ABO. We need to provide ABO compatible blood. We didn't talk about this, but we should. You asked about cross-matching and blood types at the beginning. In emergency transfusions, you can give people group O, right? But from that resource management, stewardship, respect for the donor concept, you should switch to type specific in an emergency resuscitation as soon as possible. You really shouldn't just keep using group O or group O negative blood, until you've given 20 units of blood. We really shouldn't be transfusing lots of our O inventory to non-O people. Does that make sense?
Yes, it does.
And then the RHD type. I want people to start to understand, and the physicians who are listening to this, and the public, patients, and nurses especially, I think, all of us need to start understanding the size of the risk associated with RHD mismatched transfusion. Unless you've already made an anti-D, the risk of an RHD mismatched transfusion is vanishingly small.
Say someone is transfused and they were exposed to the positive. Their blood type is A negative. They were exposed to the positive antigen. Then for some reason, 2-3 months later, they need transfused again. That's when the risk comes in. If they did indeed have an immune response.
Right. So if you're one of those 19% of people who we're observing making an anti-D, you almost always will have a type and screen before we're going to give you blood. You would almost have to have your other arm bitten off by a tiger.
Mm-hmm.
Now, Sarah didn't learn her lesson. She's still playing with tigers.
Playing with the tiger.
We told her in her discharge instructions to stop playing with tigers, but she didn't listen to us. And her tiger bit her other arm off. And, she goes to a different hospital where we don't know who she is. In that scenario, she could be given RHD positive blood, and then she would be at some risk for a mild to moderate transfusion reaction. She may also not have a transfusion reaction at all. It happens. The RHD transfusion reactions are nowhere near as serious as the ABO related ones. But in all likelihood, Sarah's not going to have her arm bitten off by another tiger or a tiger. If she does need a transfusion down the road, it'll probably be in a not emergent scenario. So where we have a type and screen drawn on her, and we'll see that anti-D sticks with you for the rest of your life. And so we'll see that on your antibody screen, and then we'll give you a negative blood.
Okay.
It's that simple.
Wonderful discussion. Thank you for coming back.
Sarah has to stay away from these tigers.
My high-risk lifestyle.
Thank you so much for joining us today. We really appreciate your time. This has been wonderful.
You're welcome.